My name is Mark Panaka. I'm a cardiologist and vascular medicine doctor at Brigham and Women's Hospital and Harvard Medical School. This module will be on perioperative risk assessment. This is for patients considering non-cardiac surgery. I have no disclosures. In this talk, I'll be referencing the ACC-AHA guidelines. And here you can see the schema. We have different classes of recommendations. Class 1 is where benefit greatly outweighs the risk, and this is where something should be done. 2A is where benefit generally outweighs the risk and it's reasonable to perform. Class 2B is that it may be considered, and Class 3 is harmful. In addition, there are levels of evidence, and I'll be citing these on the slide, as well as the class of recommendation. Well, in terms of surgical mortality, what really is high risk? And so what I've put here are some data, and these are from 1999. These are ones we classically consider, and the mortality rates. And this on the left is the type of operation. Then you have mortality if it's an emergent surgery, as well as the overall 30-day mortality for these procedures. So AAA repair, emergent status is 6%, 30-day mortality 4.7%. Carotid endarterectomy, here you can see emergent status 2.5%, overall 1.2%. And then for cholecystectomy and hip arthroplasty, you can see the numbers here. And so these are the general rates that we think about. But it's important to recognize that surgical mortality is changing over time. And here you can see risk-adjusted mortality associated with certain cardiovascular, and specifically vascular operation over time. Here the range is 1999 through 2008. And you can see that risk-adjusted mortality is going down. So the risk related to AAA repair is now about 36% lower, or 2.8%. And even that with carotid endarterectomy is lower, as well as CABG. And so overall surgical risks are going down with improved procedures and perioperative care. By way of background, it's useful to review definitions. And these are, I think, quite clinically useful categories to think about when you're considering perioperative risk or preoperative risk assessment. Is the procedure that's being proposed an emergency procedure? And that would be defined as whether a life or limb is threatened if they're not in the operating room within the next 6 hours. An urgent procedure is one in which life or limb would be threatened if not in the operating room in somewhere between 6 and 24 hours. So they need to go in the next 24 hours, although it's not an emergency. And then time sensitive is that a delay of anywhere greater than a day to 6 weeks will negatively affect the outcome. So you can imagine some oncologic procedures, you don't want to wait more than a few weeks. And a truly elective procedure is one that could be delayed for up to 1 year. So think about these. One of the key features in your recommendation will be what is the urgency of the procedure, and these are the definitions. The second set of definition is what is the risk of the procedure itself. And so we think of procedures where the risk of a major adverse cardiovascular event, or MACE, is 1% or greater as elevated risk or high-risk procedures, and low risk are those with a risk of MACE less than 1%. In the past, we've talked about intermediate risk and high risk, but the recommendations were similar. So the classification schemes have been simplified, and there are risk calculators that allow more precise calculation of surgical risk. In terms of recommendation, a validated risk prediction tool can be useful in predicting the risk of major adverse cardiovascular events in patients undergoing non-cardiac surgery. That's a class 2A. And then for patients at a low risk, further testing is not recommended before the planned operation. That's of no benefit. So in terms of the risk-validated risk prediction tools, there is the RCRI. This is simple. It's very commonly used, well-validated. It includes about 6 predictors of complications. There are, in addition, newer tools. There is an American College of Surgeons National Surgical Quality Improvement Program, or NSQIP, and there is a myocardial infarction and cardiac arrest, or MICA score. There's also a calculator, and I'll show you this on this page as a web-based calculator where you can enter the patient's surgical information for the risk calculator, and you can see that there are a number of characteristics, including age, sex, steroid use, ascites, diabetes, hypertension, COPD, and so on, and this can give you a surgical risk. So we tend to use the RCRI, but any of these risk calculators are reasonable. The next thing to recognize is that functional status is a reliable predictor of perioperative risk. It's a great data point in terms of understanding your patient's risk. We tend to express functional status in terms of metabolic equivalents, or METs. And as a reminder, 1 MET is the resting oxygen consumption for a 40-year-old 70-kilogram male. People who can achieve greater than 10 METs have an excellent functional capacity and actually an excellent prognosis regardless of their comorbidities. Patient who can do 7 to 10 METs have a good functional status. 4 to 6 METs is moderate, and that would be someone who can climb a flight of stairs or walk up a hill, walk on level ground at a rate of 4 miles per hour or greater, or do heavy work around the house. So moderate, again, something to keep in your mind is, can you climb up a flight of stairs without significant symptoms? Patients who can only walk slowly at 2 to 3 miles per hour, golf with a cart, or do something like slow ballroom dancing, and these are their sort of maximal limitations, would have sort of poor functional capacity, and that would be less than 4 METs. There are activity indexes. There's one here from Duke, and these are specific questions that you can ask and come up with a weighted score. So the questions, can you take care of yourself eating, dressing, bathing, or using a toilet? Can you walk indoors or in your house? Can you walk a block or two? Can you climb a flight of stairs, and so on? Can you run a short distance? And these factors are weighted at different, have different weights assigned, as you can see in the right column here, and can help you in terms of objectively determining someone's functional status, although you can, as shown on the previous slide here, determine fairly simply based on several questions of whether they have at least moderate functional capacity. Okay, so what is our stepwise approach to perioperative risk assessment for non-cardiac surgery? First is to determine the urgency of surgery, and we reviewed those definitions. Is the surgery an emergency? If it is yes, so this is something that needs to be done in the next 6 hours, or it could be a fatal condition or limb loss, you would do your risk stratification and proceed to surgery, and largely you would know what the risk is and then try to do things to moderate that risk, but you would just proceed to surgery. Obviously, you would not delay to do additional cardiac testing. The second step is there another condition like an acute coronary syndrome? If there is, if the patient's also having an acute coronary syndrome, you'd evaluate that and treat it according to guideline-directed medical therapy. So if emergent, proceed with monitoring and management based on your clinical assessment. If it's urgent or elective, is the patient having an acute coronary syndrome? If they're not, then you would estimate the risk. So you'd use their MACE risk based on the combined clinical and surgical risk, your calculator, for example. A low-risk patient, less than 1% mortality, you would recommend no further testing. They should proceed with surgery. If they're at higher risk, then you would determine their functional status, their functional capacity. If they can do more than 4 METs, or 4 METs or greater, then you are dealing with someone that has either excellent or moderate good functional capacity. If they have excellent functional capacity, they can do greater than 10 METs, you should not do further cardiac testing. Even if they have moderate or good functional capacity, although this is 2B in terms of recommendation, you probably want to defer any further testing. these are patients that have at least good functional status, and you would proceed with the surgery, so no further testing in most cases. If they cannot do at least 4 METs, or you can't tell, and sometimes this happens, right? Somebody who has critical limb ischemia, bad peripheral artery disease, going to have a vascular surgery, and they may not be doing anything very active, so you can't tell whether they can do 4 METs. So if they're high risk, again, it developed their functional capacity. If they can do excellent or moderate activity, no further testing. If poor or unknown functional capacity, then you want to consider other testing, and you really want to do that with an eye of whether that testing is going to alter your decision-making or treatment. So if they have poor functional capacity and it's going to change your treatment, you could do pharmacologic stress testing. That's a class 2A. If it's abnormal, then you would consider coronary assessment and potentially coronary revascularization, according to guidelines. If the stress test is normal, or if they have a poor functional capacity and you're going to go ahead and do the surgery regardless of what it shows, then the testing is not particularly useful. And either way, you'd proceed to surgery with guideline-directed medical therapy or some alternative strategy. And it may be that you determine that the surgery is a prohibitive risk and that you should consider non-invasive treatment or palliation. In terms of supplemental testing, you might choose to do some other things. So there's the 12-lead electrocardiogram. This would be in patients who have known coronary or structural heart disease. You could consider in asymptomatic patients, that's a 2B, unless it's truly a low-risk surgery, and there's no benefit in asymptomatic patients undergoing a low-risk surgery, so you shouldn't do it there. Assessing left ventricular dysfunction, so doing like an echocardiogram. You might do this in patients that have dyspnea and you don't know why. Known heart failure who've had a change in status, that's a 2A. Stable patients with LV dysfunction with no recent assessment, so they haven't had any assessment within the last year, that's a 2B. Routine echocardiography in all comers is not recommended. And stress testing with imaging, as we outlined in the prior slide, those are patients who are at elevated risk with poor or unknown functional capacity if that testing will change your management. You should not do stress testing routinely for low-risk surgeries, and you should not do it in patients with elevated risk who have moderate or better functional capacity. It's reasonable in those patients to forego stress testing. Now, this is a 2B, therefore, these are recommendations, not absolute, but in general, the utility of testing in that situation is low. So the supplemental exam, this is taken from the guidelines. It's reasonable for patients who are at elevated risk for non-cardiac surgery and have a poor functional capacity to have pharmacologic stress testing if it will change management. 2A, routine non-invasive stress testing is not recommended. Other tests you might consider, cardiopulmonary exercise testing. So you could consider this in patients where the functional capacity is unknown to determine their functional capacity. And then going on to angiography and revascularization, and this is quite a tricky topic. Coronary angiography, again, you shouldn't do it routinely, but you may do it in patients who are at more than low risk, so intermediate or high risk, and have poor functional capacity if the stress test is positive. The questions you should ask: does the patient have symptomatic coronary disease that will have a mortality benefit from revascularization now? And some of the things you might ask yourself are, am I willing to send the patient for bypass surgery before this procedure? Or am I just doing this to know the anatomy? Why are you doing the angiography? And who would you consider for percutaneous or stenting before a non-cardiac surgery? Will patients who have left main disease with comorbidities preclude bypass surgery without undue risk? And patients who have an acute coronary syndrome that would be appropriate candidates for urgent revascularization. In this case, of course, the type of intervention you do, you might alter with the knowledge that you have a non-cardiac surgery that may need to be done. If you take a step back and you look at this, these really are the indications for intervention in general. You would intervene in a patient for whom revascularization would have a mortality benefit in patients with left main disease or patients with acute coronary syndromes. There have been studies looking at patients undergoing coronary revascularization before elective major vascular surgeries. Here is a study that was published in 2004. And you can see in these patients that were randomized to revascularization or no revascularization and then followed, there was really no difference in terms of their outcomes up to 6 years after the procedure. So routine coronary artery revascularization here was not helpful. And when you look at the different variables here, you really see no pattern for benefit, whether it is for high-risk variables such as angina or positive stress testing. So the CARP trial, as shown, does not support the use of routine coronary revascularization before non-coronary surgery. A second study, this was published in 2007, looked at high-risk patients with preoperative revascularization. Now this is 101 patients with extensive ischemia randomly assigned to pre-op revascularization or not. And the outcomes shown here are all-cause mortality, or MI, at 30 days on the left and 1 year on the right. And what you can see is those patients who were revascularized actually had higher rates of adverse outcomes. This was not beneficial overall as a strategy. In addition, the COURAGE trial that looked at over 2,000 patients with myocardial ischemia and coronary disease randomized to PCI with optimal medical therapy or optimal medical therapy alone showed no benefit of routine intervention beyond medical therapy. And of course, COURAGE trial was not isolated to preoperative management, but it helps us understand the role of intervention in stable disease. What about prior stenting and antiplatelet therapy? And this is often a cause for questions and concern. In terms of the timing of elective surgery relative to coronary stenting, we prefer to have at least 2 weeks after a balloon angioplasty, 30 days after bare metal stenting, and ideally 1 year after drug-eluting stenting. You might consider intervention after or the surgery after 6 months or 180 days if the risk of surgical delay is greater than the expected risk of ischemia and stent thrombosis. Elective surgery that requires discontinuation of dual antiplatelet therapy should not be performed within 30 days of a bare metal stent or 12 months of a drug-eluting stent. An elective surgery requiring discontinuation of aspirin should not be performed within 14 days of angioplasty. Okay, so these are general recommendations for antiplatelet therapy. And here are the specific guideline recommendations. So if you have a patient undergoing urgent non-cardiac surgery during the first 4 to 6 weeks after a bare metal stent or a drug-eluting stent, you should try to continue DAPT unless the relative risk of bleeding outweighs the benefit in prevention of ischemic risk, including stent thrombosis. That's a class 1. In patients who have stents and must undergo a procedure that mandate the discontinuation of the P2Y12 inhibitor, so if DAPT is not an option, you should try to continue aspirin if possible, and you should restart the P2Y12 inhibitor as soon as possible after the surgery. This is a complex issue, and it requires weighing different risks, bleeding and ischemic risk, and therefore the management of perioperative antiplatelet therapy should be determined by a consensus of a multidisciplinary team, including a surgeon, anesthesiologist, cardiologist, and of course the patient, in terms of weighing these risks. Here is a schema. If you have a patient with a stent, if the stent was put in within 4 to 6 weeks and it's an elective surgery, as we go to the right, you want to delay surgery until the optimal period. So it'd be 30 days for bare metal stent, a year for drug-eluting stent. If it's not an elective surgery, you want to continue DAPT unless the risk of bleeding outweighs the ischemic risk. If the stent is a drug-eluting stent that's been in for 30 days, more than 30 days, but less than a year, Then you want to ask yourself, does the risk of delaying the surgery, is it greater than the risk of drug-eluting stent thrombosis? If the risk of delay is greater, then you would do the surgery and you would aim for 6 months. If no, then you would delay surgery until the optimal period, the same as we have up here, 30 days for a bare metal stent, 1 year for a drug-eluting stent. If it is not within these time periods, then the question will be, does the surgery demand discontinuation of P2Y12 inhibitors? If no, continue DAPT. If yes, continue aspirin and restart the P2Y12 inhibitor as soon as possible after the surgery. In patients with no coronary stent, so patients undergoing non-emergent, non-urgent, non-cardiac surgery who've not had stenting, you may continue aspirin when the risk of cardiac events outweighs the increased risk of bleeding. That's a 2B, okay? So continuing it, but we don't generally initiate aspirin in patients undergoing elective non-cardiac surgery who have not had prior coronary stenting. We usually don't take this time to initiate it, although I'd say you could determine that based on the risk profile of the patient. And this, of course, doesn't apply to carotid surgery. Beta blockade. If patients are on chronic beta blockade, they should be continued on that. Postoperatively, you may use them as needed based on the clinical circumstances, particularly if there are arrhythmias or other things that occur. It may be reasonable to begin a beta blocker prior to surgery if they're intermediate or high risk on testing, or if they have 3 or more RCRI risk factors such as diabetes, heart failure, coronary disease, prior stroke or renal insufficiency, or they have some other long-term indication. Initiation of beta blocker therapy the day of surgery may be harmful. So if you choose to start a beta blocker, you want to do it enough ahead of time, titrate the dose appropriately as you would normally with an outpatient, and generally use longer acting agents to get them on a stable regimen. You don't want to just start someone on a beta blocker and send them directly to the operating room. In terms of statin therapy, if they're on a statin, they should continue it. That's class 1. Perioperative initiation of statins is reasonable in patients undergoing vascular surgeries. And perioperative initiation may be considered in patients with clinical indications according to guideline-directed medical therapy who are undergoing elevated risk procedures. For people on angiotensin converting enzymes or ARBs, you would continue them, it's reasonable to continue them, that's a 2A. And if they're held before surgery, you want to restart them when it's clinically feasible. So now let's transition to valvular heart disease. Significant valvular heart disease increases cardiac risk. So we know that, and then the role of assessing valvular heart disease depends on the context. So if you have a patient that needs emergency surgery, you want to establish an accurate diagnosis. What's the type of valvular heart disease? What's the severity? You want to use that as part of a multidisciplinary team to inform your anesthetic approach and your general approach to the patient, the setting, what type of monitoring you're using. And you might consider for some patients higher levels of perioperative monitoring, so arterial lines, PA catheters, use of transesophageal echocardiography, and the use of the ICU for close monitoring. If it's an elective surgery, you're going to be thinking about the valve in a different way. And really you're thinking, is this a valve that needs to be replaced or repaired? Have they reached an indication to that? And should it be done prior to the surgery? Overall, should it be done and will it impact the risk of the surgery? In terms of class 1 recommendations, it's recommended that patients with clinically suspected moderate or greater disease of valvular stenosis or regurgitation undergo preoperative echocardiography if there's no prior echo within 1 year or there's been a change in their clinical status or exam since the last evaluation. So get an echo if they haven't had one in the last year, or even if they've had one in the last year and there's been a change. They're doing worse or their exam suggests worsening heart failure. For adults who meet standard indications for valvular intervention on the basis of their symptoms or severity on imaging, valvular intervention before elective non-cardiac surgery is effective at reducing perioperative risk. So if the valve needs to be fixed and the surgery can be delayed without any harm to the patient, that may be beneficial. Now, in general, patients with stenotic valvular lesions are at higher risk than those with regurgitant valvular lesions, although both are at increased risk of heart failure, but stenotic valvular lesions may be more difficult to manage. In patients with aortic stenosis at elevated risk, elective non-cardiac surgery with appropriate intraoperative and postoperative hemodynamic monitoring is reasonable if they have asymptomatic severe aortic stenosis. That's a 2A. In patients with mitral stenosis, those going for elevated elective non-cardiac surgery using appropriate intraoperative and postoperative monitoring may be reasonable in asymptomatic patients, although they may have severe MS by valve morphology if it's not favorable to commissurotomy with a balloon. In terms of aortic and mitral regurgitation, elevated risk surgery with appropriate intraoperative and postoperative monitoring is reasonable in asymptomatic patients. That's a 2A. And even patients with asymptomatic severe AR and a normal ejection fraction, again, they may proceed as a 2A class recommendation. What about implantable devices? Well, this does require communication between multiple teams, including anesthesia, potentially the electrophysiologists, and the surgical team. You want to coordinate before the surgery. For patients with ICDs who have preoperative reprogramming to inactivate their tachytherapy, they should be on continuous cardiac monitoring during the period of inactivation. You should have defibrillation equipment available. And systems should be in place to make sure that their ICD is reprogrammed to active therapy before you stop the monitoring and discharge them to home. So we've talked about coronary disease and we've talked about valvular heart disease. Pulmonary vascular disease also is associated with significant perioperative risk. Who are the high-risk patients? Well, if they have group 1 pulmonary hypertension, so pulmonary artery hypertension, or if they have other forms of pulmonary hypertension and they have high pulmonary pressure. So if the systolic pressures are greater than 70 millimeters mercury, or there's a moderate or greater RV dilatation or dysfunction, or that the resistance calculates to more than 3 Wood units, any of those would be high risk or increased risk. Or if they have class 3 or 4 symptoms that are attributable to pulmonary hypertension, any of those would be increased risk. Targeted therapy for pulmonary vascular disease or pulmonary hypertension should be continued unless it's contraindicated or the patient's unable to tolerate it. And we would strongly recommend consultation with a pulmonary hypertension specialist prior to operation in terms of how to optimize the patient and characterize the risk. Another condition you may see is hypertrophic obstructive cardiomyopathy. Recognize that if these patients become vasoplegic, if they become hypotensive because of a reduction in their systemic vascular resistance, if there's volume loss, preload reduction, these are all things that might worsen their obstruction, reduce diastolic filling and cardiac output. So this could really get them into trouble. So you want to avoid overdiuresis. You want to monitor them closely and generally avoid inotropes if you can. In patients with arrhythmogenic RV cardiomyopathy or dysplasia, this is associated with heightened mortality, and we would recommend consultation with electrophysiology and careful monitoring. Beyond just characterizing a patient's risk, the operation's risk, and the medications, you may also talk to the anesthesiologist and consider in a multidisciplinary fashion the anesthetic consideration. So there are different options for anesthesia in many cases. There may be local options, regional options, monitored such as IV sedation with or without local, or general anesthesia. Use of a volatile anesthetic or total IV anesthesia is reasonable for patients undergoing non-cardiac surgery, and the choice is determined by factors really other than the prevention of myocardial infarction or ischemia. But neuroaxial anesthesia after abdominal aortic surgery may reduce the risk of MI, that's a 2A, and epidural anesthesia may reduce perioperative or preoperative cardiovascular events in patients with hip fracture. Other intraoperative considerations: prophylactic use of IV nitroglycerin is generally not effective and not recommended. Transesophageal echocardiograms are not routinely recommended, but you may consider them in patients where there's hemodynamic instability. Pulmonary artery catheters are not routinely used, but can be considered in the setting of an underlying medical condition that significantly affects hemodynamics and that you can't correct before surgery. So your patient with aortic stenosis or mitral stenosis that you're concerned about, that has severe disease, maybe they're asymptomatic and you're proceeding, you could consider the use of a PA line. In terms of surveillance, there is a lot of discussion about the use of biomarkers. And I'll say that any elevation in troponin in the pre or post-operative setting is prognostically important, does predict poor outcomes, but does not always alter the management of the patient. So if the patient has signs or symptoms that suggest ischemia, unstable coronary syndrome, or myocardial infarction, you would measure troponin and obtain ECGs and monitor as you normally would. If there's a patient who's high risk for a perioperative MI, but there are no signs or symptoms of ischemia, the use of doing this sort of testing is really unknown. How that's going to change your management really is unknown. And routine screening of troponin in patients who are asymptomatic is not recommended. So several take-home messages and really things to think about in your patient prior to surgery. Are they endorsing symptoms? Are they describing symptoms, or are there other features that would make you concerned that they're having an acute coronary syndrome or that they've had a recent acute coronary syndrome within the last month? Obviously, that is a patient where you need to highly consider the risks of surgery, and really you'd want to treat their acute coronary syndrome according to guideline-directed therapy, medical therapy. So there's ACS. The second thing is, do they have decompensated heart failure? And this is based on your clinical assessment. If there's evidence of decompensated heart failure, you usually like to optimize that before sending them to the operating room. The third thing to think about, is there a significant arrhythmia, and one that you would do something about even if they weren't going to have surgery? So they have high-grade AV block, including complete heart block. Are there symptomatic ventricular arrhythmias, new VT, or uncontrolled atrial arrhythmias such as atrial fibrillation, symptomatic bradycardia as well? Are there significant arrhythmias, and they're the ones that you would do something about even if the patient came to your clinic and wasn't considering surgery? And then finally, severe valvular disease, particularly stenotic valvular disease like aortic stenosis and mitral stenosis. So keep these four things in your mind, and if none of these are present, generally your patient will be at acceptable risk, particularly if they have at least a moderate functional status and can do 4 meds. So other take-home messages. Emergent surgeries. You're going to assess risk. There's really no role for additional testing unless you can do it very quickly, but at least for coronary assessment, it's not going to change your management. They need an emergent surgery. Your goal there is to understand the risks and to do things to try to attenuate the risks and to get them through the surgery. If it's an urgent or elective surgery, assess the patient. Functional tolerance is the best single predictor of outcomes. See the patient, find out what they can do, but take a careful history. Be specific. If they say they can walk, how fast can they walk? Can they walk up a hill? Can they really walk up steps, and how many steps? When you ask patients if they have steps at home, they might be talking about the 3 steps to get into their house versus a full flight of 13 or 14 steps. So ask and really understand what their functional status is. Now, I'll say often, particularly for elective surgeries, I walk with the patient, I walk them up the stairs, and I watch what they can do in terms of assessing their functional tolerance. Third bullet here, testing is reasonable in certain situations. Routine echoes, routine stress tests, routine biomarkers in patients without symptoms not going to be helpful, but there are patients for whom these tests are indicated, as we reviewed, and particularly you want to think about how they're going to change your management before you order them. So test when indicated and when it will change your management. When you think of coronary revascularization, try to think of it in terms of the patient, regardless of whether or not they're having surgery. So sort of ignore the surgery. Do they have an indication for a coronary revascularization? And then think about how it may impact the timing or the risk of surgery. Is there a mortality benefit to intervention? What's the best way to do it? And recognize that if you put a stent into somebody before they need a non-cardiac surgery, you're going to have to deal with their antithrombotic management, and that there may be trade-offs then in terms of bleeding and thrombotic risk. So try to think about the role of revascularization in terms of the long-term for the patient and what you would normally do in the clinic. And then, for these complex patients that have congenital heart disease, pulmonary hypertension, patients who have complex pregnancies, or where there's complex antithrombotic therapy decisions, a multidisciplinary assessment should be considered. For example, patients with pulmonary hypertension, get a pulmonary hypertension specialist involved or a congenital heart disease specialist involved, because these are cases that can be very complicated and multidisciplinary decision-making can improve outcomes for the patient. Okay, so here are some citations. Clearly the guidelines on perioperative cardiovascular evaluation are quite helpful here, and you can see links on this slide. All right, let's proceed to our questions. So question number 1, you're assessing a 65-year-old woman, and she's planned to have a laparoscopic cholecystectomy. She does heavy housework at home. She can carry groceries up a flight of steps at a brisk pace. She never gets short of breath. She has no chest pain. She does not really do anything more than this, but based on this history, how do you assess her functional capacity? Is it A, excellent? Can she do more than 10 METs? Is it B, at least good, 7 to 10 METs? Is it C, at least moderate, 4 to 6 METs? Or is it poor, less than 4 METs? So the answer here is that she has at least moderate functional capacity. She can do heavy housework and she can walk up a flight of steps. So she can do at least 4 METs, if not more. Question number 2. You're assessing a 65-year-old woman prior to a planned laparoscopic cholecystectomy. She does heavy housework, including carrying groceries up one flight of steps at a brisk pace. She has no shortness of breath or chest pain. How should you think about stress testing in this patient? Is it A, reasonable to forego stress testing because she has a reasonable functional capacity? Should you do the stress test to get a better sense of her functional capacity? Should you do the stress test just to see if she has high-risk disease? Or you should use stress testing to guide revascularization. So in this case, it's reasonable to forego stress testing. She's asymptomatic. She has at least a moderate functional capacity. It's unclear in this situation that doing more testing like a stress test, and certainly doing a revascularization in her, given that she's asymptomatic, doesn't have an acute coronary syndrome, and doesn't have heart failure, none of those would be particularly useful for her. So here it's reasonable to forego stress testing. Question number 3. Which of the following medications does not reduce cardiovascular risk when initiated routinely before non-cardiac surgery? And here the answer is aspirin. There are debates about the utility of aspirin in this setting. So the traditional teaching is that routine use in all comers may not be beneficial, but of course patients that are on aspirin because they have atherosclerosis should continue.